Good afternoon, everyone. Welcome to CRTI's 2021 Symposium. I am Deepa Kolaseri, Scientific Director, Cancer Research Translational Initiative, or CRTI, at the Masonic Cancer Center. As you all know, every year, CRTI has been organizing a mini symposium on different areas of cancer research. And this year, the focus is on data resources for population-based cancer research. In this meeting, we will discuss 6 data resources: SEER-Medicare, Fairview Cancer Registry and Electronic Health Record data, ACS NSQIP data, Marketscan data, National Cancer Database, and Population Assessment of Tobacco and Health. Each topic will have 2 speakers followed by a Q&A session. And each speaker will get 5 minutes to present. As Nick mentioned, please keep your questions for the discussion session, and you may use the raise hand feature and we will unmute you so you can ask the questions, or you can type your questions via Q&A module. So this is the format of the meeting. Before we get into the meeting, I would first of all thank the Faculty Planning Committee members, Drs. Helen Parson, Dorothy Hatsukami, Heather Nelson, Ann Joseph, and Karen Kunz for bringing up wonderful suggestions and identifying the speakers for us. On behalf of the Cancer Center leadership, I would like to thank all the speakers for accepting our invitation to present today. We very much appreciate your support and time. Without any further delay, I would like to welcome our first speaker, Helen Parsons. Dr. Parsons is an associate professor in the School of Public Health, Division of Health Policy and Management at UMN. She is an expert in the areas of cancer survivorship, administrative claims data, health policy, adolescents and young cancer survivors, Medicare, Medicaid, chronic disease, and quality of care. Welcome, Dr. Parsons.
Thank you. Today, I will be presenting an overview of the SEER-Medicare data. The SEER-Medicare data are a linkage of 2 distinct data sources: the Surveillance, Epidemiology, and End Results Cancer Registry data sponsored by the National Institute are linked with data from the Medicare program. The SEER program collects information on cancer incidence as well as survival and currently covers approximately 26% of the US population, as can be seen in the map on the right. The Medicare program is a federal health insurance program that's available to individuals who are 65 and older, as well as select disabled adults. Currently, the SEER-Medicare data include individuals diagnosed with cancer between 1999 to 2017, as well as their Medicare data through 2018. There's a wide variety of information available from the SEER cancer registries, including demographics of the individuals, including their sex, age, year and place of birth, their race and ethnicity, as well as their marital status. You also have a wide range of information about the cancer itself, including cancer type, stage, histology, some tumor markers that vary by year, as well as lymph node testing and positivity. You are also able to understand and know the month and year of diagnosis. In terms of treatment from SEER, you can identify surgical treatment as well as radiation therapy that's provided as the first course of treatment, and these are grouped into categories. And finally, you have information on survival and are able to evaluate both overall as well as cancer-specific survival. From the Medicare program, you're able to identify individual-level Medicare enrollment as well as healthcare bills for individuals who are enrolled in the Medicare program. Specifically, as you can see on the right, you can identify information on enrollment for these individuals, including monthly enrollment in specific components of Medicare, demographics of individuals in the Medicare program, and whether or not they receive additional help to pay for their out-of-pocket costs, in addition to some other information. You can also identify hospitalizations for these individuals, including detailed claim level information on the dates of service, the diagnosis and procedures that happened while they were hospitalized, the providers that cared for them, as well as the payments for those hospitalizations. You're able to also identify outpatient and physician visits for these individuals, including similar information around when they received the service and the diagnosis and procedures that occurred, as well as payments. Outside of those settings, you can also identify home health and hospice and durable medical equipment that these individuals receive. And finally, prescription drugs for those that are enrolled in the Medicare Part D prescription drug benefit, including the drugs that they received, the date their prescription was filled, the prescriber and pharmacy that provided those, as well as their payments. Overall, the SEER-Medicare data has a number of strengths that include its population-based nature, which currently represents about 98% of those that are over 65 are enrolled in the Medicare program. And it allows for tracking of care received over time through healthcare claims for these individuals. And finally, you have a set of common coding, diagnoses, and procedures that allows you to look in a similar way across individuals receiving care. As a result, there's a number of common types of studies that are conducted with SEER-Medicare data, including program evaluations, such as evaluation of new payment models or policy changes. People also commonly look at economic evaluations in this data, such as treatment impact or cost effectiveness. Commonly, they also look at resource use and outcomes, such as questions around health equity, geographic variation, treatment trends over time. And finally, questions are commonly addressed looking at effectiveness research in this population. However, not all studies are well suited to using the SEER-Medicare data, and there are a number of limitations. Specifically, it's limited to individuals who are enrolled in Medicare, which is predominantly those over the age of 65. We don't have information or on their healthcare bills for services that are provided prior to their Medicare enrollment. This data is also limited to covered benefits, and not all services are covered by the Medicare program. And not all individuals are enrolled in all parts of Medicare, such as Medicare Part D. We additionally have limited physiological and behavioral data in this linked data set. Specifically, physiology data is lacking, such as BMI and blood pressure. And we have information on whether someone received a test, but not the results of those tests, such as a lipid panel or pathology, as well as very limited information on behavioral factors such as smoking, alcohol use, and exercise. And finally, there's limited information on Medicare Advantage enrollees, and these are individuals who enroll in private plans to receive their Medicare benefits, and Medicare has not historically required these individuals to have their individual treatment records submitted, and that represents about 30% of the population in Medicare. If you're interested in using SEER-Medicare, there's a number of considerations. First, there's a wide range of additional training you can consider taking, such as free online training offered by the National Cancer Institute at the website below. There's also a large learning curve with these data. They're large, complex data, and they're structured as multiple records or files per individual per year. So just keep that in mind. This is not a quick turnaround study database. Third, approval is study specific. And so each new research question requires approval by the National Cancer Institute before conducting your study, even if you've previously obtained the data. And finally, be sure to reach out. We have a wide range of expertise in using administrative data in SEER-Medicare specifically within the Academic Health Center. And there's a number of resources, including courses for you to help analyze these claims data and help you get started. I'm happy to answer any questions, so feel free to reach out at the email indicated.
Thank you, Dr. Parsons. That was a wonderful presentation. I'd like to invite our next speaker, Stephanie Jarosek. Dr. Jarosek is an assistant professor in the Department of Urology, UMN. She is the co-director of the Clinical Disparities Program and director of workshop for Research Data Assistance Center. She has over 10 years of experience working with Medicare data, and most of her experience has focused on using Medicare data linked with SEER cancer registry data in the context of prostate cancer. Her major area of interest is healthcare use at the end of life. Welcome, Dr. Joseph.
Thank you very much for the introduction, and thank you for the opportunity to talk about my project. This project is actually a few years old, but I thought it had some features that were really well suited to the SEER-Medicare data, so that's why I decided to present this today. This was a project that I did in conjunction with Dr. Sean Elliott in the Department of Urology. He had a grant funded by the American Cancer Society to look at the long-term risk of severe urinary adverse events following prostate, or the grant was actually for all pelvic cancers, but I'm going to talk about the prostate cancer piece today. So just to give a little bit of background, we know that men who have treatment for prostate cancer, local treatment, will have some adverse effects associated with that sometimes. It's about 5 to 10% of men based on estimates in the literature. It can be anything from a cystitis from radiation to incontinence to bladder neck contracture, which makes it difficult to urinate. However, the parallel treatment comparisons are rare. So the radiation oncologists are following their patients, the surgeons are following their patients, but we don't necessarily get to compare events following surgery and events following radiation. We also don't have a lot of data long-term because, physicians, it's hard to track your patients beyond 5-10 years out of your clinic. So generally, and even in RCTs, they don't usually have that long of a time horizon. So we didn't have a lot of information on the long-term effects of prostate cancer treatment, and this is especially interesting for radiation because of the cellular damage that happens with radiation. It tends to have a longer time course before it shows up as a problem. We also, we know that elderly men in general may have trouble with urinary issues, and it's not that often that you get to look at how does a non-cancer population compare to a prostate cancer population that's been treated. So the SEER-Medicare data are suited for looking at some of these issues. We can, using the SEER information, we have information on diagnosis of cancer, and also, we can limit it to a cohort of men who, for whom any one of these treatments might be a viable option. With prostate cancer, it's unique because it's the same cancer presentation could be treated in a variety of ways. So we can look at that, and then from the Medicare side, we can follow people over a long time course. With the exception of Medicare Advantage, generally, if someone's enrolled in Medicare, they're enrolled until they die. So we can look and follow them across multiple healthcare settings, inpatient settings, outpatient. You can also look across health systems as well. So you're not limited to your own health system. And then the Medicare program also supplies, the SEER-Medicare program supplies a non-cancer control population that is the same, it's got the same geographic location as the SEER registry so that you're able to get a good comparison. Our hypothesis for this project was that radiation would have a higher rate of urinary adverse events than surgery. This was based on Dr. Elliott's experience. He's a reconstructive urologist. So the one limitation, of course, with Medicare administrative claims data is that it's billing data. So we limited our analysis to severe urinary adverse events. We weren't going to rely on just a one-off, bill for incontinence. Also, whether or not a patient would complain of incontinence, it may not even make it onto a bill from a healthcare setting. So we looked at very severe adverse events. These are grade 3 or 4 according to the CTCAE. So they required a procedure. So this was bothering the men enough that they came in and they wanted to be treated for it. There were a variety of treatment categories, but when we looked at any of the urinary adverse events, this is the unweighted numbers. We saw that if we start at the bottom, we do have a control population that has a non-negligible amount of adverse events. And then we also saw what we expected with radiation, that there was kind of a linear increase. When we look at the radical prostatectomy group, the surgery group, this wasn't unexpected. It wasn't unexpected, the shape of the curve. We were a little bit surprised by the steepness of it, but it's not unexpected that they would have adverse events right away that would kind of level off over time. But then we also saw that for the men who had both radical prostatectomy in addition to external beam radiation, they actually did end up having the worst events. So we knew that patient characteristics, when we're looking at observational data, these men weren't randomized to treatments. Older men tend not to get surgery, so we knew that there were patient characteristics that we wanted to control for that would determine, what treatment they're going to be getting, and also probably have some influence on whether the treatment would result in an adverse event. So we used inverse probability of treatment weighting to kind of adjust for some of these things. What we found was that the men who had any prostate cancer treatment did have higher rates of urinary adverse events than men who didn't have cancer. And we definitely found that having a combined treatment, both surgery and radiation, was the worst. However, if you look our external beam group, I don't know if you can see my cursor, but that was actually the lowest group. And when we looked at the largest type of complication, bladder outlet obstruction, we found that results were similar in that most of the treatments were associated with a higher hazard of receiving or of having a urinary adverse event. Actually, external beam radiation therapy was not associated with that. So understanding, how these relate to a control population was really helpful, I think, as we were thinking. And you may have noticed that our hypothesis was not supported. And that's something that I think that population-based studies can really provide. The intuition from a tertiary care academic surgical center was that we would see a lot more issues with radiation, and that wasn't the case. So I think, we saw some of the patterns that we expected. I would say this was one of the studies that we did. We also looked across cervical cancer and rectal cancer, which is another wonderful thing about the SEER program. You can look at a variety of cancers. And this one was looking at the time to the first event only. We did some other studies where we were looking at men who had enough problems that they needed to be treated multiple times for their adverse events. But again, this is observational data with some of those inherent limitations. And this was limited to an elderly population, but I think that it was helpful for us to be able to look, in a broad population across the country and see what shook out from our treatments. Oops. So that is all I had. I apologize for my speed talking. There we go.
Thank you, Dr. Jarasak. The session is now open for questions. You can either raise your hand, you can use the raise your hand feature or type your questions in the Q&A module.
So again, just a reminder for folks that do have questions today, there's two ways you can ask questions. You can use the raise hand feature to indicate you have questions and I'll unmute you. And the other is to type your question in the Q&A module. At this time, doesn't appear that there's any, oh, here we go. Dr. Parsons, do you see the question that just came in?
I do, yeah, so there's a, thank you. So Heather Nelson asks what monetary resources are needed to use the SEER-Medicare data. So that's a great question. The SEER-Medicare data are not free. I didn't go into it because I only had a short intro, but one of the benefits of having a cancer center and resources that have used these data in the past is that you're able to work with other investigators who may have already obtained the data. And as long as it fits with the cancer site and of the data that they have, there is not, you don't have to pay to reuse the data. You have to get approval for it as long as you're working in collaboration with an investigator who may have the data. If you do want to purchase the data yourself, you maybe the particular cancer type is not available yet at the university, you can go to the SEER-Medicare website and they have a cost estimator. So if you just into your browser type SEER-Medicare cost estimator, it'll pull it up and you can tell them how many years of data you're interested in looking at over what time period and how many cancers, and it will pull up an estimate of the cost. I would say that on average, if you're just looking at a single cancer, it's a few $1,000s for the cost if you don't have access to the data internally. But one thing to keep in mind is that you can't request the entire database. That's just a rule from the SEER-Medicare program. So Stephanie, I have a question for you. You've been using the data for a long time. What are some pieces of advice that you typically give people that are getting started with this data?
I think you actually covered a lot of what I would tell people is that it is complex. It will take some time to get a project up and running, and so I think, I don't remember if you talked about the a 3-paper rule that we sometimes talk about, but it's because it's difficult data to work with. It's really helpful if you can kind of think ahead and not just have one analysis that you're planning on doing, but multiple analyses that might come out of constructing a cohort and trying to put all of the measures together from the data. That's probably my main piece of advice if you're just getting started. And I would also say, you mentioned that I'm from ResDAC. ResDAC doesn't specifically support SEER-Medicare data, but we do have some resources about looking in Medicare data for various things. So I would just want to plug our website for that.
Yes, and there's a lot of free online workshops that you offer as well. So that's a great resource. We had another question from Shlomo Marmer, who will be presenting later today, asking what are some of the biggest or the greatest barriers to using the SEER-Medicare data? I would say that there's a number of challenges, but they're not. It's not something that you can't overcome. These data are very large. It's not a data set that you can get in the mail and then just try and put on your laptop. First of all, that's not allowed, but second of all, it would crash your computer just because of the sheer size of the data. It's it can be close to half a terabyte to a terabyte, depending on how many cancer sites you request. And just really one of the other things to consider is the complexity of how all of the files and components of the data set fit together, because people are billing. These are healthcare bills, and there's different rules and regulations that change over time. And so I would say partnering with someone who has used these data before is a really important first step, so that sometimes you don't know what you don't know. And so working with somebody that has used these before is really important. We have another question from Stephanie. How do we find out what kind of SEER data is available locally? I would say that you can feel free to reach out to either myself or Stephanie. I'll volunteer you as well to just give us a sense of your question, what cancer you're interested in, and we can reach out to people who may have access to the data already. All right, and then finally, Heather Nelson asks, is there a work group of people using SEER-Medicare? And I would say informally, yes, we have a work group of people that have we've been working on with these data for a number of years now. So I think if you wanted to, again, just reach out to us, we can get you connected to those people. And but that's a great consideration as well, of thinking more broadly about creating a work group. So thanks for that question.
I just promoted Dr. Marmo to panelist, and if there are any other panelists in our general attendee audience, if you could just raise your hand, you'll float to the top of my screen. It'll be easy for me to promote you as well. But yeah, just one quick note there. So thank you.
Wonderful.
Okay, any other questions for this session? I think then we can move on to the next session. The next session is on Fairview Cancer Registry and electronic health record data. And I invite Dr. Parsons to invite the speakers for the next session.
Wonderful, thank you. So our next speaker for today is Ms. Vidya Ramesh, who is the Data Analyst Team Manager for the Clinical Informatics Shared Services at the Masonic Cancer Center. Today, she is going to give us an overview of the Fairview Cancer Registry data, as well as the electronic cancer record data within our organization.
Thank you, Dr. Parsons. Hello, everyone. I'm here to present the process of extracting EHR data for research. So we are SIS team, which stands for Clinical Informatics Shared Services. SIS is part of CTSI BPIC and is a shared service for Cancer Center. We are a dedicated team for cancer data extractions. Today, I'll be highlighting the process by taking registries as an example. Properly designed and executed patient registries can be more effective for clinical practice and research. These can also be used for enhancing data collection and management processes. We have developed several automated registries using data from EHR over the past few years. Building disease-specific registries are helpful to have unified definitions for the data elements used across various research projects. The next slide is on methods. EHR data from EPIC flows through Fairview Clarity and then into HST's CDR, which is often called Clinical Data Repository, and is available extraction, usually registries and treatment plans. And these registries are built on a PHI compliant environment using best practices and procedures. This slide shows the.
Yeah, it would be a good idea to maybe stop sharing your video just so your bandwidth doesn't slow down.
Environment for information exchange. Just a second.
Okay, video, you'll want to share screen again. There you go. Yeah, good job.
Is it clear now?
It's still loading on my side. There we go.
Okay. So is it clear?
Yeah, it's clear. We can see it now,
Okay.
and just go ahead and keep talking, and hopefully it won't be any bandwidth slow down.
This slide shows the information exchange architecture. We get data from Fairview and UMP, including tumor registry data. We also get data from our internal sources, such as Encore, RedCap, and public databases as records from state and UMLS data and RxNorm data from NIH. We also manage and provide access to other databases such as Marketscan data. This is a partial list of the registries that we have developed over past few years. We have developed registries for urologic cancer, gynecologic cancers, and heme malignancies. Usually, cancer registry cohorts are determined using the following sources. The first source we tap into is a tumor registry, which is abstracted by Fairview cancer registrars. This contains data on patients who are initially diagnosed and have undergone at least part of initial treatment at UMN. This is the data that gets reported to state by Fairview. The next source is Analytic Case Cancer Registry. This is also abstracted by the same team, but has data on all patients who are currently treated here at UMN, regardless of their diagnosis location or treatment level. Since these databases are often behind in data entry, we use EPIC for up-to-date patient list. That is, as per study needs, we filter EPIC data using ICD or CPT codes in conjunction with treatment plans. Displayed here are few registry contents at a higher level. We have extracted surgery information, genomics, medications, treatment plan, vitals, etc. And finally, I was asked to present how much it would cost for these data extraction, and here is a slide on that. We are subsidized for cancer center PIs at the rate of $95 per hour. However, cost of extraction varies by project and is dependent upon the requirement. This is just a high-level overview with few examples. We recently had an extraction for ovarian cancer patients who had pelvic mass removal surgery and had calcium and albumin tests ordered within 30 days prior to surgery. This was a study feasibility request, and the PI provided us with all codes, ICDs, CPTs, and lab codes that go with the data set. So it took us only 45 minutes to an hour to complete the extraction end to end. Another example is an extraction we did for Dr. Arora, which is prevalence of use of potentially inappropriate medications in older patients undergoing allogeneic HCT and its impact on early outcomes post-HCT. For this, the cohort was identified by study team. CIS then extracted raw data for medications, cleaned it up and formatted by applying rules and confirming it with the PI. It took us around 15 hours to complete this project. For any new registry projects, we usually estimate around 80 hours for phase 1 and provide a new estimate if the project expands to phase 2 or so. The next slide is on how to start a request. You can initiate the process by going to the BIPIC website and placing a request by clicking on the schedule a BIPIC consultation. Then one of our analysts will contact you to start the consultation process. They will gather requirements and provide you the consultation report with an estimated budget for the project. If your study is a retrospective study and all the data is extracted by us, then the study will be eligible for abbreviated IRB. You just need to submit our consultation report to the IRB. And here is the link to our BIPIC request procedures, which has granular details of our procedures and processes. You can contact us by emailing cis@umn.edu. We also hold office hours every third Thursday of every month from 1 to 2. And here is a link to our website. Thank you.
Thank you, Vidya. All right. So next up, we have Dr. Mukta Arora, who is a professor of medicine in the Division of Hematology, Oncology, and Transplantation at the medical school here at the University of Minnesota. Her expertise is in older transplant recipients, graft versus host disease, and late effects after transplant. And due to scheduling, she has kindly pre-recorded her talk. She's currently in clinic and wanted to make sure there was not any background noise. So what we'll do now is have Nick pull up the pre-recording and then she will be available live to answer questions after the recording.
Thanks so much. I'll go ahead and share screen. Stand by, everyone.
Hi, I'm Mukta Arora. I'm a physician in hematology, oncology, and transplant, and I'm going to talk to you today about the Fairview Cancer Registry and its applications. Until recently, medical records were captured on paper and required intensive review. Over the last decade, practitioners are now using electronic records to capture their clinical findings and conclusions. The labs are entered in these EMR, and the practitioners enter the diagnosis, list of medical problems, medications in the EMR. So what is a cancer registry? It's an information system designed for cancer data collection, storage, management, and analysis, and it's a type of disease registry. Why are cancer registries important? We know that cancer is a major national burden. Cancer is the second leading cause of death amongst Americans, only second to heart disease. The estimated direct cost of cancer care in the US in the year 2015 was over $80 billion. There are two types of cancer registries, a hospital-based registry and a population-based registry. A hospital-based registry can provide data for improvement in patient care, professional education, administrative information, clinical research, and to monitor site-specific treatment measures. Population-based registries can be used for cancer prevention, early detection, to determine cancer rates and trends, to assess patterns of care and outcomes, for purposes of research, and to evaluate control efforts. A hospital-based cancer registry can be used to capture the disease, its stage, treatments, hospitalizations, complications, survival, and relapse information. The slide here shows a graph which used a cancer registry for the data and shows the rates of new cancer cases as well as the death rate estimated over time. I'll now describe a study which recently used Fairview Cancer Registry data and was recently completed and published in BBMT. The study is titled Use of Potentially Inappropriate Medications in Older Allogeneic Hematopoietic Cell Transplant Recipients. So the main aims of the study were to compare the prevalence and predictors of use of these PIMs. These PIMs are potentially inappropriate medications in older versus younger allogenic transplant recipients. And amongst the older recipients, the study aimed to determine the association of these PIMs with mortality, toxicities, and discharge disposition. So the study population consisted of a retrospective cohort of 354 patients who underwent an allogenic transplant at over 40 years of age. Use of PIMs was compared in 114 older recipients to 240 younger recipients. PIMs, the use of these PIMs was defined as the number of days a patient received one or more doses of PIMs between day -14 to +28. So day 0 is considered as the day of transplant. So what we wanted to do was to evaluate the peri-transplant use of PIMs, mostly when the patients were admitted for their transplant. So this was defined as, the time period was defined between day -14 to +28. So this data set used the resources from Fairview Cancer Registry as well as the BMT database. We retrieved a list of patients and the dates of transplant from the BMT database. And we created a list of PIMs, these medications, from literature review. From this information, the informatics and data access team provided us with dates of admission and discharge, number of days each medication was administered, as well as the discharge disposition. So we analyzed this data, and what we saw was that GI and GU medications were used at a higher rate in older recipients as compared to the younger recipients. We also saw that use of these PIMs led to a 5 times higher likelihood of discharge to a nursing home or rehab facility versus discharge to home. So to conclude, the main purpose of these cancer registries is to collect accurate and complete cancer data. What is the importance of this data? It's very important in terms of cancer control, epidemiological research, public health program planning, and patient care quality and improvement. In the end, I'd like to thank you and to thank the organizers for inviting me to present this data.
All right, wonderful, thank you. So at this time, please feel free to either raise your hand or type your question for the panelists into the Q&A box at the bottom of your screen. And while we wait for some of those questions to come in, I have a few for our speakers. It would be helpful if you could speak to some of the considerations that if someone's interested in this data that they should keep in mind when they're getting started with a project, just based on your experience. If you had gone back and were starting over again, what would be some helpful things for researchers to know?
So the main things is to, when I started reviewing this data, is to know exactly what you want. It's, and what is available. So we had a defined data set, which was very useful. But then looking at the medication data is hard. So it's medications can have different names, and to know exactly what we wanted and what dates we wanted it for, and the fact that medications can be listed as ordered but not given. So to go back and re-revise what we wanted constantly, it could be approached in a different way if we knew exactly what's available and what's needed. Also, I think we need to work closely to make sure that we're getting accurate information. So if once the data is provided to us, then what we need to do is verify it and essentially look at the medical records and make sure that we're getting accurate data and confirm that. But I think it's a great resource, and if we work closely with the team, then I think we can really get a lot of information that would otherwise take a really long time to retrieve.
Thank you for that. Related to that last point you just made, I would be curious to see from your perspective, what are some of the aspects of this data set that you find most useful in your own work relative to other data sources that you've used before?
So I think what's unique about this data set is that it allowed us to focus on the quality improvement part of it, so that what we identified was that in our practice, what are the medications that we shouldn't be using, right, in older patients that we know that have been recommended by the Beers criteria to be inappropriate in older people. So then we look for the alternatives, and then we come up with guidelines that we should be using in our practice in transplant patients. So that's huge for our patient population to minimize their side effects.
Wonderful, thank you. All right, it doesn't look like we have any other questions in the Q&A. So what I'll do now is we're running a little ahead of schedule. So I'd like to thank our speakers, Vidya and Dr. Aurora, for presenting on the Fairview Cancer Registry. And I think now we will move on to our next data set, which is the American College of Surgeons National Surgical Quality Improvement Program data set. And for our first speaker, we have Dr. Elliot Arseniadis, who recently completed a fellowship at Cleveland Clinic in Florida and is going to be joining us very shortly as an assistant professor in the Department of Surgery. He's a colorectal surgeon. And his research expertise is in using administrative data to understand surgical outcomes and disparities in care. Today, he'll be presenting an overview of the American College of Surgeons National Surgical Quality Improvement Program data. I'd like to, just before he gets started, briefly thank him for stepping in at the last minute to present on this topic, as well as our next speaker, Dr. Elizabeth Haberman. So thank you for pinch hitting, and I really, really appreciate your time. So with that, feel free to share your screen.
Certainly. Well, thank you for that introduction. Good afternoon, everyone. I'm Elliot Arseniadis from the Division of Colorectal Surgery, Department of Surgery, and I'll be presenting on the American College of Surgeons National Surgical Quality Improvement Project. So ACS NSQIP as it's commonly called, really started at the turn of the millennia. It was born out of a real need by surgeons to have a better understanding of sort of the quality of care that we were providing to patients undergoing various surgical procedures. Up until that point, administrative data was available, but was really insufficient to capture the granularity and the level of detail we were looking for when looking at our surgical outcomes in various patient populations. And so the American College of Surgeons, really the largest professional body representing all types of surgeons, came up with this first of its quality programs. Several more specific to various disease states would follow, but this is the overarching quality program that is still in use today. Briefly, it includes over 700 participating hospitals throughout the United States. The data is collected by surgical clinician reviewers. At least one is hired by each hospital. Traditionally, these are people who come from a clinical background. Very oftentimes, they come from a nursing background, and they undergo training with the American College of Surgeons to become certified as surgical clinician reviewers. And essentially, their job is to scour the electronic health record of patients who are selected for inclusion into NSQIP and record, manually all of the preoperative, intraoperative, and then postoperative variables that go into the NSQIP data set. As you can imagine, this is quite a painstaking process, and it is a heavy investment for hospitals to choose to enter into the NSQIP program. And so that has been a limiting factor. Certainly not every hospital that is performing surgery in the US is participating in this, but it does have a very large sample of both academic and community hospitals that participate. Notably, the VA, where NSQIP was born out of, has its own version of VA NSQIP. All surgical specialties are represented, so general surgery, colorectal surgery, gynecologic surgery, orthopedic, vascular surgery, even transplant, all specialties are represented in the data set, and all types of procedures are represented, from your most basic appendectomy to your more complex, liver resection, esophagectomy, that sort of thing. Of note, not every procedure performed at every participating hospital is abstracted and recorded, but rather a slice of the usual percentage of those surgeries that are performed. So at the University of Minnesota Medical Center, we might perform 1,000 appendectomies per year, but only a few hundred of those will actually be abstracted by the NSQIP nurses, since that probably gives a very reasonable sample of what we do, versus only, probably 50 or less liver resections occur during the year. So it's more likely that the majority, if not all of those liver resections, those more rare surgeries, are being recorded. So NSQIP cannot be used for, gross amount of surgeries performed, but rather just a sample. Both pre, post, and intraoperative variables are recorded. There is a very long list of preoperative comorbidities like chronic kidney disease, COPD, heart disease that are recorded. Preoperative diagnoses that the patient is undergoing their procedure for, like Crohn's disease or rectal cancer, are recorded. Unfortunately, when looking at this from the cancer context, there is some very basic data, but not really very rich cancer-specific data. For instance, there is a variable for whether or not they've received chemotherapy in the recent past, or whether they've been on some sort of immunomodulating medication, but it won't say what kind, it won't give the doses, or whether or not they completed a typical round of neoadjuvant therapy or radiotherapy. Procedure variables include things like whether or not the case was emergent, urgent, or elective, whether or not the patient had to be hospitalized preoperatively before undergoing their operation. And then finally, the real value of NSQIP came out of its recording of the 30-day postoperative complication rate. This included things like surgical site infection, kidney failure, death, etc. Again, unfortunately, there were no cancer-specific outcomes. For instance, no information on the quality of the surgical resection, no information on whether or not there was recurrence, and there was a hard stop at 30 days postoperatively. So I certainly would hope you wouldn't get your cancer recurrence within 30 days. And there is a very long list of variables and outcomes that are recorded in NSQIP, available at the website at facs.org/qualityprograms. All of the data from the NSQIP program is held within the participant user file, or PUF. And this is what one would query when utilizing NSQIP. It records data for each year since the year 2005. 2019 is the most recent data we have. So as an example, in 2005, there were over 150,000 cases from over 121 hospitals reporting data. In 2019, we had over 1 million cases reported from over 700 participating hospitals. And then looking at what types of cases or numbers of cases being performed in 2019, something I'd be interested in, colectomy, nearly 50,000 procedures were abstracted from over 300 hospitals. Pancreatectomy over nearly 8,000 from 165 hospitals, and then prostatectomy over 8,000 cases from 125 hospitals. So it is a large data set, again, not representative of the entire surgical population, but NSQIP has gained quite a lot of traction in the past 2 decades. So it does give one a very good overview of surgical practice and quality in the United States at this time. So how do you use NSQIP? Any researcher at UMMC can access NSQIP. Our surgical clinician reviewer is Jennifer Wood, and she's available at this website. Maria Ivasovich from the Division of Surgical Oncology is our surgeon champion for NSQIP. Essentially, to do a research project, you would email Jennifer first with your clinical question, and then if you could provide things like ICD-9 codes for diagnoses that you're interested in, and CPT codes for the procedures that you are interested in, that is usually extremely helpful. So I know, like Dr. Eric Jensen right now from the Division of Surgical Oncology is doing a project related to pancreatic fistula or pancreatic leak following a pancreas resection. So things he would do would be provide things like the CPT codes for pancreas resection, and then the diagnoses codes for leak, and then whatever other preoperative variables he'd be interested in. Data output comes in the usual format in SAS, SPSS, or even Excel. From the projects I've done utilizing this database, it is always helpful to work with an actual statistician, especially one familiar with NSQIP, of which there are several here. So again, while not cancer specific, in instances where patients undergoing a surgical resection for a tumor are your patient of interest, and where 30 days post-op is enough, of a window to obtain the data you're interested in. And NSQIP provides some of the highest quality and most reliable data of any real, national database. So for the right question, it is certainly very, very useful.
Wonderful. Thank you for that overview of the NSQIP program. So next up, before we take questions, we're going to have Dr. Elizabeth Haberman, who is a professor in the Division of Healthcare Policy and Research at the Mayo Clinic, present on an application of the NSQIP data. Dr. Haberman's research focuses on the quality and outcomes of surgical and perioperative care, and she's had significant experience in working with and publishing research studies using the ACS. So with that,
thank you. Can you see my slides, Ellen?
Not quite. It looks like it's just loading. Try one more time. Great, now we can see them.
Okay, great. Well, thank you for having me here today to talk about one of my favorite data sets, the ACS NSQIP. So unlike the cancer registries that we're going to be hearing about today, both SEER and NCDB, cases are selected slightly differently. So again, patients are identified using ICD-9 diagnosis codes or CPT codes, as was just mentioned in the last presentation. Unfortunately, there's only one ICD-9 or ICD-10 diagnosis code, so we can't get into some of the detail available with other cancer data sets, and I'll speak about that in a bit. Other data elements were presented in the prior presentation, but again, there's surgical specialty where the patient was admitted from. Also something we've been using a lot are preoperative as well as postoperative laboratory tests and comorbidities. There's multiple CPT procedure codes. Every CPT that's performed under the same anesthesia is recorded, whether it was conducted by the primary surgical team or another surgical team coming in to perform a different part of the procedure. So it can be a really nice resource for looking at combined cases. There's also intraoperative data on timing, on incision to close, anesthesia start and stop, blood administration, and so on. Discharge destination, and then this 30-day follow-up. One reason I really like NSQIP is because we have the 30-day follow-up regardless of where the patient may be readmitted or even undergo a reoperation. So it's not limited just to following patients, say at Mayo Clinic and they were readmitted at the U, we would see that in NSQIP. So some of the advantages have already been presented. It's a really large data set. In 2019, there were over 1 million cases. It's free to participants. It's HIPAA compliant, so it may be IRB exempt or very easy to get through the IRB. And it includes both inpatient and outpatient procedures. Some other large data sets like Nationwide Inpatient Sample would include inpatient procedures only. We've already heard about the abstracted data, which is one of its biggest strengths, and the 30-day follow-up from the time of procedure. But there are disadvantages. Again, there's only one diagnosis code. There is information on comorbidities or some other medical information, but as far as an ICD-9 or 10 diagnosis code, we only have one that's assigned at the end of the case. There's no institutional identifiers or characteristics, which can be very frustrating at times when we would prefer to know whether or not the cases that we're observing are taking place at academic medical centers or community medical centers. And as mentioned, there's very limited cancer information in the overall NSQIP participant user file. There's no cancer staging, histology grade, METS, margin status, or cancer-specific outcomes. However, one thing I did want to highlight to this group are the procedure-targeted participant user files, and these have additional variables specific to these procedures of interest. And I've highlighted in bold those that may be specific to cancer procedures. And so I know that with my colleagues, we've looked at some gynecologic oncology investigations with these participant user files that are procedure targeted that have additional staging information, or so that we can learn more about the patient's cancer itself. So I was asked to provide an example of an ACS NSQIP investigation. And it is a bit old. This was published in 2014, but I think it's a real way to see how a simple explanation of how NSQIP can be very useful, and whether this, while this was a straightforward analysis, it did result in practice change at our institution. So this arose from a surgical resident that I mentored, Dr. Chris Schubert. He's now HPB staff at Johns Hopkins. And he came to me and said that the diagnosis was not being appropriately considered when looking at outcomes following Whipple procedures. And if diagnosis was considered, at the time it was just divided into benign versus malignant. And he felt that the way the pancreas was and the duct size really varied by diagnosis, but wasn't just benign versus malignant, it was more complex. So we were able to investigate this question using NSQIP data. So using NSQIP and ICD-9 codes, we identified all of these different indications for undergoing pancreaticoduodenectomy. You can see we had a number of malignant indications and then also benign indications. We also use the NSQIP data to look at these 30-day outcomes: surgical site infections, sepsis, major morbidity, which would be any major complication within 30 days of the procedure, and length of stay. So what we found is that some of the diagnoses performed more similarly to each other, with our low risk diagnoses of pancreatic cancer and chronic pancreatitis, both having lower risk in blue. In orange, you can see our higher risk diagnoses, which was duodenal neoplasm, neuroendocrine neoplasm, and bile duct and ampular neoplasm, regardless of whether they were benign or malignant. And so there was no difference in the p-values when we looked across the blue groups or across the orange groups. But these two groups performed differently from each other with a p less than 0.001. This relationship held across every procedure that we investigated, from complication, organ space infection, sepsis or septic shock, any major complication within 30 days, or prolonged length of stay. So this was a very brief overview on how we used one of these larger data sets to inform our quality improvement at our institution. And so using these data, we identified a gap in our current institutional practice and concluded that patients undergoing pancreaticoduodenectomy should be stratified by diagnosis to more accurately reflect their risk for postoperative complications and the complexity of care that's required. So again, this took place many years ago, but building upon these data, we looked at our institutional data and developed a pathway for patients undergoing Whipple procedures. And then once this was in place, we evaluated its implementation and found that we saved over $1 million in the first year of implementation. And it all started with this first ACS NSQIP project. So if you're interested in learning more, I think you've gotten some great resources from within your institution. I think ACS NSQIP has one of the best websites. There's so much information there. You can see every data variable that's collected for each of the data sets that I've mentioned. There's also a conference called the ACS Quality and Safety Conference that's usually held every summer. Last summer, of course, was converted to virtual, and I haven't seen what's happening this year, so I'm not sure if it will be taking place in 2021, but it may be an opportunity for 2022. However, NSQIP is a very frequently used data set in the research presented at the American College of Surgeons Clinical Congress, which is scheduled to take place this October in person, so we'll see. And with that, I'd be happy to take any questions.
All right, thank you both. What a great set of presentations. So first up, it looks like we do have a question. Dr. Hatsukami has raised her hand if you'd like to unmute and ask your question.
Dr. Hatsukami permission to unmute, so she'll be able to unmute at this time now.
Oh, sorry. No, I didn't have a question.
Oh, okay. Your hand was raised. I'm sorry. Yeah, I didn't mean to call you out.
Yeah, sorry about that.
Well, okay. So if anyone has any questions, please feel free to post them into the Q&A board within Zoom. I think just to get us started, we've talked a lot about some of the caveats and challenges. Could either one of you speak a little bit to the timeline in terms of accessing and using the data, how long it typically takes to do a project using these data?
I would say that in my experience, NSQIP has one of the shortest timelines of any data set. As long as you have a time with your surgical clinical reviewer, your NSQIP point person to get the data. And once you have the data and you have someone who knows how to use SAS or STATA or R, and the fact that it's IRB exempt, at least at university or at Mayo Clinic, sometimes we've made an abstract in 2 days.
I can't boast that I've had a 2-day turnaround time, but my own schedule is the limiting factor usually with NSQIP projects, not the speed at which the data becomes available. So it's fast.
Great, thank you. Okay, we have a question from the audience. Dr. Heather Nelson asks, is case selection for inclusion in the NSQIP data decided at the local level?
Sort of. So with the caveat that I am not an expert on this part of NSQIP, there is a random sort of choosing, and it's not done by the surgical clinician reviewer. Again, from what I've been told, they enter, all of the cases from the prior month, into NSQIP, and NSQIP then tells them which ones that they are going to abstract. So they may list that 50 appendectomies were performed in the past, in the month of December 2020, but then NSQIP will randomly decide which of those, 50 are going to be manually abstracted. And again, for a very common procedure, a smaller percentage will be chosen. For something like an esophagectomy, by and large, pretty much all esophagectomies will be entered in and manually abstracted because it's such a rare procedure.
So I will say this is not changing a bit. So,
okay.
So you may be more up to date than I am. I'm most familiar with the NSQIP Essentials program, which is how Mayo Clinic participates, which is not the procedure targeted puffs that I showed you that have more cancer detail. We can use those for research as a NSQIP participating institution, but as an institution, we actually don't participate in the procedure targeted puffs. So at Mayo Clinic, what happens is we have a list of CPTs that NSQIP includes. It's based on their primary procedures, and it's almost every specialty. I don't believe it includes transplant, and it definitely doesn't include cardiac, but every other surgical specialty is included. But not every surgical procedure is included. So for example, in urology, they came to me looking at kidney stone procedures, and it was not on the NSQIP CPT list at the time. So when we have this CPT list that NSQIP gives us at Mayo Clinic, it's on an 8-day cycle. So starting on Monday, they'll have say 100 procedures that they need to look for in the next 8 days that match the CPT codes that are collected by NSQIP. And so usually they would probably get it on the first day because we are a high volume institution. So that would be on a Monday. And then 8 days later, the next week on a Tuesday, they would do the same thing. So it's pretty random procedure limited by the CPTs that NSQIP asks us to collect. But then if you're in the procedure targeted, so the pancreatectomy procedure puff, I think you need to abstract every pancreatectomy.
Great, thank you both for those answers. All right, and then the final question that I had is, thinking about getting started with these projects, what costs should researchers consider to try and create a budget if they want to use these data?
I think it depends on how savvy the individual is with coding. If they feel comfortable coding in SAS or R, for example, the cost may be zero other than your time. So I certainly have worked with surgical residents who have experience coding, and they have done projects for $0. If you work with an analyst, it could be anywhere from up for a manuscript, I would say 60 to 80 hours of an analyst time, up to many months, just depending on how complicated the project is. But as we've mentioned, the data themselves are free.
Thank you. Well, thank you both for your presentations. This is a great resource, and I appreciate your insights on the strengths and ways to use the data. All right, so next up, we're moving to our next data source, which is the Marketscan data. And first up, we have Dr. Joel Farley, who is a professor and associate head in the Department of Pharmaceutical Care and Health Systems in the College of Pharmacy at the University of Minnesota. Dr. Farley is a pharmacist and a pharmaceutical outcomes researcher who specializes in the evaluation of programs and policies affecting medication use in patients with chronic health conditions. Today, he will be presenting an overview of the Marketscan data for us. Dr. Farley.
Thank you. I'm curious if you're seeing the right screen.
We can't see it in full screen. Yes, great.
Okay. Wonderful. So thanks for the opportunity to speak about the Marketscan claims data resource. This is a resource that we actually brought to the University of Minnesota about 1.5 years ago now. And I'm going to talk a little bit about the populations that are covered in the data, what the data actually contain in it, and a little bit about some applications that people might consider using these data. So let's start with the populations that are actually covered in the data. So there are actually 2 different populations that are actually covered in the Marketscan data source. The first is the commercial claims and encounters data, and then the second is the Medicare supplemental and coordination of benefits population. The commercial claims and encounters data actually collects information from across 100 actually, it varies from year to year. The last look that I had, it was about 140 different payers that were contributing data to this data source. So these are large health plans and employers, and basically what it's looking at is a large population of commercially insured beneficiaries. One thing that's somewhat interesting about this data source is the data are basically aggregated across all of the different health plans to give you a full summary of commercially insured beneficiaries. The plans themselves are actually blinded. So I know that sometimes people have questions that they want to look at related to changes in health plans, coverage, and that would be something that would be a little bit more difficult in these data because it's really aggregated across all the data and the plans themselves are blinded. The other thing I mentioned is that the data source actually shifts in terms of which plans actually decide to contribute data from year to year. So we now have data from 2013 through 2019. I don't have the population for 2019 presented here, but as you see, between 2014 and 2015, a number of plans did actually stop participating in the Marketscan data source. Still a very large population, the commercially insured, depending on what year you need data for. It could be anywhere from 47 million people to 29, 28, 26, 27 million people. The other source is the Medicare supplemental and coordination of benefits data. This is coverage of a Medicare covered population. It's somewhat different from the data that you might obtain from ResDac directly getting Medicare data, and that these are Medicare beneficiaries that have coverage through an employer as well. So this tends to be somewhat of a healthier population, and the benefits tend to be more generous than you might see through a Medicare population. So that's something to keep in mind. The other thing with this data source is that the population that provides Medicare data is somewhat smaller than the commercially insured population. And for a lot of the cancers that you might be interested in studying, that could be a rate limiting factor in terms of whether or not to use these data. So this is a summary of the data tables that actually come with the data source. And this is a typical claims data resource. So, the data are basically aggregated depending on what type of medical claim is actually submitted. So there are, 2 different types of claims that you might be familiar with if you use claims data. There's both the institutional claim, which might cover the hospital fee that someone has, and the hospital stay, and then there could also be a claim that would come out related to the professional services, so the physicians that are actually providing services as part of that stay. So each of these data sources is obtained into a number of different tables, and there are a couple of different inpatient tables that summarize some of those services. There's an outpatient record that you can use to look at physician services, emergency room use, and outpatient facility use. And then there's also prescription drug claims information that actually come through the data. So these would be retail prescription claims that are paid for by the insurance plans, as well as a red book resource, which you can use to actually merge NDC information to the actual medications that a patient is using, as well as the therapeutic categories that are affiliated with that medication. The other thing is there are a couple of different enrollment tables. This gives a little bit of information on the plans themselves that contribute data, whether or not it's an HMO, a PPO, a point of sale plan, et cetera. So that information is there, and you also have information to be able to see whether or not someone is continuously enrolled in the data source, and a little bit of demographic information on things like gender and the age of the patient. So how might I use these data? One thing I like to remind people, and this is where I tend to get the majority of questions around whether or not this is an appropriate resource for me to use, is a reminder that these are claims data. So this is really a record of billing for the health plans and a record of services that the health plan is paid for. So it covers services, you know, in the inpatient, outpatient, and prescription drug file. You have information in here about payment itself, so how much the health plan actually paid out to the provider, for example, the patient's deductible or co-payment amount that was actually attributed with that service. So that information tends to be pretty robust in here. There's also some limited enrollment information, as I mentioned. So, you know, to get some idea of health plan coverage, age, gender, the type of plan that someone is enrolled in. I like to remind people as well, though, that, you know, these are claims data, and there's a number of pieces of information that you don't have in these data. For example, you basically have what is billed for and paid by the health plan. You might not actually have the service that was provided. So there can be inconsistencies sometimes in what is actually coded versus what is actually provided to a patient. For services used at home, things like prescription medications, you'll have a history of whether or not a medication was actually filled at the pharmacy. You won't know anything about once that patient gets that medication at home, whether or not they actually consume the medication or not. You have information about whether someone received a clinical test or, you know, had a lab drawn. What you don't get out of that, though, is the actual results of the lab. All you have here is the payment information. Sometimes people want to look at these data for things like racial variations in the uptake of medications. That is not an appropriate use of these data because detailed demographic information also aren't in these data. Things like race, education, and income are not directly available. They're not important to the health plan necessarily, and therefore they're not coded as part of the enrollment process. Services paid for outside the health plan. So if something is paid for directly by a patient and they decide not to use their insurance, you wouldn't pick up on things like that. And this one comes up quite a bit with cancer-specific studies. This doesn't actually have a really good accounting of mortality information. What you see is that someone became unenrolled and they're no longer contributing data to the data source. What you don't necessarily know is why, whether or not that person is no longer enrolled with the insurance, or it could be that mortality might have contributed to that reason for unenrollment. So as I mentioned, we've had these data now for about 1.5 years. The way that we obtained these data was actually through an institutional license. This covers all of the academic health center schools, and it also covers Carlson School of Management. One nice thing about these data is the data are already downloaded, and we have them available now from 2013 through 2019. You can see there's a link there for submitting a request to BPIC to actually put in a consultation to obtain these data. So basically, if you're looking to use these data, it's just an internal data use agreement that you go through to sign off on some of the check marks to make sure that we're appropriately using the data based on the contract that we signed with Marketscan. So there's no fee to actually conduct research with these data, which is kind of a nice thing if you have a project that you're thinking about doing or potentially need data to support something like a pilot project to get counts or estimates on the number of people that might be using a medication or might have a procedure. This data source might be something that would be available to you to run numbers on something like that. There is something built into the contract, though, that if you do end up receiving funding through a grant, that then there becomes a fee affiliated with the data. For federal and foundational grants, that fee is $30,000 per grant. So it's basically building in a promise that if that grant is funded, you promise to pay Marketscan that fee to use the data as part of that grant. For commercial, so if you're working with an industry sponsor, for example, that fee is actually $60,000. There is also a small fee built into the data for dissertation projects, but these are available for dissertation projects. And that's a $1,000 dissertation fee in a process that they outline for you to be able to obtain these data for dissertation projects. So in the year and a half that we've had these data, there have been 30 different data requests that have been submitted to use these data thus far. And there are 15 ongoing projects, and I kind of put in a little bit of some of the departments that are using these data. And you can see that it kind of runs the gamut of different departments, and it's interesting to see the types of questions that come out of these data. They really do vary between epidemiological investigations, medication adherence, cost-related studies, and other things. I just want to mention one other thing here, and that's a little bit about some of the contractual considerations if you're thinking about using these data, just to keep in mind. As I mentioned, they don't want health plans identified directly in these data. And so there is something built into the contract that you won't attempt to identify which health plans might be contributing data and which patients are covered by those health plans. If you're looking at doing something at any small level, like a region, there are some contractual limitations on being able to look at anything at a level that's smaller than the state. So if I'm looking at something like only in the Twin Cities metropolitan area, that would be somewhat difficult in these data. And I think part of that comes back to that first question, that it might, lend to identifying the individual health plans that are contributing data. Access is only available to university employees and students. That doesn't mean that you can't have a contract with an external organization. It would mean that that external organization would only be able to see aggregated data. They wouldn't have direct access to get in and use the data itself. And then they have a contractual limitation that data cannot be linked to any other data sources without their prior approval. So that's just a few things to be aware of if you're thinking about using these data. So that's all I have on the Marketscan data. Thanks for listening.
Thank you for the overview. And before we take questions on
Can't hear you for a second here.
Yeah, something with audio. Your audio could, you want to start over?
Yeah, of course. Thank you. Probably had a connection issue. So before we take questions, thank you for the overview presentation. We'll move on to Dr. Pamela Lutze, who is an associate professor in the Division of Epidemiology and Community Health at the School of Public Health at the University of Minnesota. He is an epidemiologist whose mission is to identify potentially changeable factors that and other chronic conditions. Today, Dr. Lutze will be presenting an application of using the Marketscan data.
Yes, so today, thank you for the introduction. Today I'll be talking about the comparative effectiveness of venous thromboembolism's treatment strategies in general in cancer populations. And so I'm a cardiovascular epidemiologist by training. For those of you who aren't familiar with venous thromboembolism, it occurs when there's a blood clot in the venous system that can then possibly break free and travel through the heart and into the lungs, where it causes a pulmonary infarction. About 1 million Americans experience VTE each year, and important to this group, about 1/3 of VTEs are provoked by cancer. And so cancer patients with VTE are a special population of interest. Now, in terms of VTE treatment, oral anticoagulants are the standard of care. Traditionally, warfarin was the only option in the US. However, since 2012, several direct oral anticoagulants, or DOACs, have now been approved for the treatment of VTE. And so, there are some general considerations among these DOACs, which are most efficacious in terms of preventing VTE and mortality, and also in terms of which have the lowest bleeding risk. Also, are there differences in effectiveness by population subgroup? So for instance, the elderly who are at greater bleeding risk, or those with impaired kidney function. And then thinking about cancer patients with VTE, there are some special considerations there as well, since cancer patients have an inherently different bleeding profile. It's also worth noting that cancer patients were not included in the DOAC randomized controlled trials. And at the time we began this work, DOACs were not approved for use in cancer patients, though we were quite certain that off-label use was taking place. So this is just a flow chart to give you an idea of the numbers. We started out with nearly, this is for years 2011 through 2016, nearly 500,000 VTE patients. After we applied very strict eligibility criteria, we were down to 175,000. And this is an early paper we wrote, simply looking at trends in the use of oral anticoagulants for VTE primary treatment. And so this, I think, is a potential valuable application of these data in that you can see changes in use of medicine or other treatments over time. So this goes from Q1 2012 through Q4 2017, and percent is on the y-axis. As you can see, there was a dramatic shift from essentially everyone being on warfarin to less than 20% of VTE patients getting warfarin for their primary treatment by Q4 of 2017. So thinking about bleeding risk in the general VTE primary treatment population, and these are hospitalized bleeding events. We did a matched analysis with high dimensional propensity scores comparing apixaban to rivaroxaban, and found that apixaban was associated with lower risk. When we looked at apixaban versus warfarin, a similar association with apixaban being superior. And then when we compared rivaroxaban to warfarin, there was no association between those two treatment strategies. And this forest plot just shows additional analyses stratified by sex, age, and known kidney disease status, just to kind of show that with this sample size there, even for a disease as rare as venous thromboembolism, there is potential to do meaningful subgroup analyses. So now thinking about cancer, which is the focus of this group, when we further restricted our population to VTE patients with evidence of active cancer, we had nearly 27,000 patients, and those patients experienced 1,200 hospitalized bleeding events. And here are the hazard ratios for the primary comparisons, again, matched and with high dimensional propensity scores. So, comparing to, and we had to collapse the DOACs group because at the time there weren't enough DOAC users. But you can see that there was suggestion that the DOACs were protective versus warfarin. It wasn't statistically significant. The confidence intervals were wide. Similarly, when we compared DOACs to low molecular weight heparin, the estimates were nearly identical. And then low molecular heparin versus warfarin was at essentially 1. So from this analysis, we concluded that these analyses suggest that DOACs are safe in the context of cancer. And given how little information there was on this topic, especially at the time, our hope and thought is that this will contribute to guidelines, given that the DOACs are easier to use for several reasons. So many collaborators here at University of Minnesota. And at this time, I, together with Joel, can take any questions.
Thank you both for your presentation. While we wait for questions to come in through the chat, I think I'll just kick us off by asking both of you. I know that you both use a number of different secondary data sources in your work to answer a variety of questions. What questions do you think about as you're trying to decide over the other? What benefits are there in using the Marketscan data relative to other administrative data or other sources?
Want me to start? So, I mean, I think it really comes down to your research question. And, you know, what you don't want to do is fit a data source into your research question. And so I mentioned the example of race not being in the Marketscan data. And if that's really your key question, then don't try and fit, you know, your question into the Marketscan data source. It's not the best resource for you to use. Another thing, if cancer staging is very important, that information isn't going to be available in the Marketscan data source either. So something like the SEER-Medicare source may have more information in that than, you know, you would get from the you know, data sources that I talked about. Same thing with kind of the, you know, thinking of that Medicare population. If your population of cancer patients is very old, you know, and tends to be on average 70, 75, and you're going to use the commercially insured population, that tends to be less than 65. So you're not getting a really representative sample of it. So I think I kind of think about those types of things in terms of which data source to select.
I echo that. You know, Marketscan's key strength is in its size. It's very large and it has younger individuals. And so just an example of another project I did, we looked at testosterone therapy, particularly in the context where it wasn't indicated and risk of VTE. And we actually did that, you know, with a case crossover design. So we were able to look at both a rare exposure and a rare outcome and, you know, hopefully yield meaningful results. But it is, you know, the not having mortality is a very important consideration for some of what I'm doing too.
Another question that I had for both of you is, when researchers are thinking about a timeline and how long it might take to get a project in the Marketscan data, what are some broad estimates? I know every project is different that you might provide for individuals.
Yeah. I think people that I work with are often surprised at the amount of detail that goes into actually programming, you know, what goes into these data sources. So, you know, to do this well, I think there's this kind of perception that the data are already available and therefore it should be able to, you know, pull the answer out within a month or two. To do these well, it really does take a period of a year, you know, 2 years, depending on the question. Now, with that said, once you've had some of that programming time down and you've got some experience and some of the applications of programming tend to be somewhat similar, and you have some of that, like medication adherence is a big one for me. I've got pretty good coding on that. You can kind of churn these out a bit quicker, but it really depends kind of on the experience level and whether or not you have programmer support.
Any other questions? I guess one last final question before we move on. For those that are interested in using the data, what's the best contact or who should they reach out to learn more?
So there are some pretty good resources around the Marketscan data now that BPIC has, and I think that initial consultation with BPIC is kind of where I point people to start off. They have information on the you know, data use, the data dictionary, et cetera, that you can actually look through. And then I think there are people that are now kind of using these data, and, you know, I put myself out there. I'm happy to answer any questions that anyone has about using the data. But, you know, I'd probably start with BPIC.
Thank you. All right, so we're going to move on to our next data source, and it sounds like my audio is fairly bad. So what I'm going to do is turn off my video in hopes of preserving some of my bandwidth. So from here, our next data source that we're going to present an overview on is the National Cancer Database. And for this data resource, we have first up Dr. Jane Wei, who is an assistant professor in the Department of Surgery in the University of Minnesota Medical School. Her research focuses on surgical oncology and cancer outcomes for breast and melanoma, as well as soft tissue sarcoma and other cancers. And with that, you can take it away.
Thank you for inviting me to speak today. Before I start, I just want to make sure that everyone can see my presentation in full screen, and that everyone can hear me okay? Perfect.
Yeah.
So I am the state chair for Minnesota for the Commission on Cancer. And the University of Minnesota Medical Center gained Commission on Cancer accreditation in 2019. And that's really allowed us to utilize this database. And so what is the National Cancer Database? It is comprised of data from Commission on Cancer accredited programs across the nation. The COC, or the Commission on Cancer, is a program from the American College of Surgeons in partnership with the American Cancer Society. And in the meetings for accreditation, for setting standards for the Commission on Cancer, it really is a partnership between the American College of Surgeons and representatives from the American Cancer Society. So it truly is a partnership. This is a map that shows the 1,500 COC accredited programs across the US and as well as in Puerto Rico. The cancer programs comprise about a quarter of the hospitals in the United States, but they do treat over 70% of all cancer patients. And so they do have a good representation of cancer treatment, at least in COC accredited sites across the country. The program began in the 80s, and since then there's been about 35 or 36 million cases that have been logged. Having said that, the data that is available is a little bit more recent for research use. And so this data that is collected from the various cancer programs is hospital-based data. And so each center or aggregate of centers apply for COC accreditation, and their cancer programs do have to meet certain criteria from a cancer treatment provision standpoint. But once a center is accredited, their data that are submitted then are part of the NCDB, the National Cancer Database. And it is a clinical cancer registry system. And so clinical data is collected. And all cancer types are collected, and they're actually sorted mainly by disease site. So for example, if you were interested in head and neck cancers, that would be the disease site that the data would be provided for, and then underneath that disease site umbrella, specific histology codes can then be identified. As I mentioned, because this is a clinical cancer registry system, the data that is submitted from each center is abstracted by certified registrars. As part of accreditation for the COC, there's actually CME and training requirements for the tumor registrars at each individual program. And so the data is relatively robust in terms of data that's submitted. It's actually abstracted by people who have been trained to look through the charts and pick out the data that is requested. As far as, so the National Cancer Database, the reason why data is abstracted from each COC site is for quality improvement at the individual site level. And so each program actually has access to their own data, and that's actually part of COC accreditation, that we review our own data. But for research purposes, all of that data is pooled into a national file, and the participant use file that's available currently has data from 2004 to 2017. It is de-identified data, so here at the University of Minnesota, it is IRB exempt. They collect patient characteristics data, so age, gender, race, socioeconomic status. They collect tumor characteristics. So specifically, things like year of diagnosis, AJCC staging is a huge one that is collected in NCDB. They include both the clinical stage as well as the pathologic stage, which can be important for certain cancer types. And as I mentioned, the tumor data and the data files are organized by site of disease. They collect treatment data, of course, and the data that is collected for cancer treatment includes the first course of treatment. So basically, the treatment that a cancer patient receives after initial diagnosis. And that can include multidisciplinary treatment. It's not necessarily just the one modality that they receive, but all of the upfront treatment that they get at first diagnosis. And the primary outcome that's collected in NCDB is survival. They do collect survival data at 30 days, 60 days, and 90 days, as well as the 5-year overall survival. In addition to survival data, also readmission data is collected. That's only limited to 30 days. So for someone like myself, who's a surgeon, readmission rates for particular cancer surgeries may be something that we can utilize the NCDB to answer these questions. There are limitations to NCDB. I mentioned that it's the first course of cancer treatment that's collected. So with that, it also means that salvage therapy is not recorded. Salvage therapy being somebody's diagnosed with cancer at time 0, they receive their initial treatments, and then, for example, they recur 2 years later and get additional chemotherapy. That second course of chemotherapy does not get recorded. Or if they have, subsequent surgery or something like that, that's also not recorded. As a corollary to that, also recurrence data is not well collected. They actually do collect recurrence data, but it's not complete, and the NCDB does not recommend using their database for looking at recurrence. Finally, the first course of treatment that's collected, the data that's collected is actually just the first course of treatment in 6 months, within the first 6 months. So if somebody was going to receive neoadjuvant chemotherapy and it stretches for longer than 6 months for whatever reason, then the collection of the data for that patient's cancer treatment is going to be limited because it only captures the first 6 months. And finally, data that is collected for treatments that are sequential. So chemotherapy sessions that are multiple in nature, radiation therapy sessions that are given over time. It's not possible to assess compliance with these treatments. It's basically coded as yes, chemotherapy, recommended, given, or not given. And same with radiation. So it's not possible to tell who actually completed their entire course of recommended treatment. With regards to systemic therapy, there are some bonuses in that they do collect things that are outside of chemotherapy. So they have data on endocrine therapy, for example, in breast cancer, where these are pills that are not chemotherapy. And they do collect data on things like immunotherapy, which is sort of the latest, greatest thing in cancer care. As far as additional treatment data that's collected, surgery is collected as the most definitive surgery. So if somebody has, for example, a small diagnostic procedure like a diagnostic laparoscopy to identify the extent of disease, and then they have their definitive resection at a later date, only the definitive resection is going to be collected. Finally, as far as surgical data, the NCDB is superior to things like SEER in that they do collect margin status, so resection margins, whether they're positive or not, lymph node evaluation, how many lymph nodes were evaluated, of those, how many are positive. So there are some tumor-specific data that, that the NCDB has that other cancer registries do not. How do we apply for data? This is a website that basically has all of the information to apply for participant user files. And they actually have a pretty good list of available variables as well as the application requirements. So speaking of that, the proposals, they do require an online application of a proposal. You do need to identify the research team, the disease site of interest, the cohort of patients, and then some variables of interest. And finally, for the online application, a letter of support from the cancer program here is needed. And then this is the website where the online application occurs. There have been some questions about timing. How quickly do we get data? My experience is that the turnaround time, once all of the data elements in the application is submitted, the turnaround time is actually pretty quick, within a few days. Prior to 2020, the online application was only available a couple of times a year, and there was a definitive window of when you could apply. But since I think the beginning of 2020, that has changed to the online application website being open 24/7, and basically you can apply whenever. As part of the application process, they do have you do have the option of a technical review. Somebody from the NCDB can review your research question to see if this is something that's feasible. So for researchers here, how do we request for the PUF use? Basically, our local cancer program has identified some criteria for researchers who want to utilize the NCDB because the data is contributed to by the clinical faculty. Basically, the requirements are for the primary investigator to, the research team to, somebody from the research team to either be a member of the Masonic Cancer Center or to be clinical faculty involved in the diagnosis, care, and management of cancer patients. Again, they have to be on the research team. They don't have to be the PI. If you're interested in obtaining a letter of support and for access to that online application website, you just have to send the research proposal and who in your research team meets those criteria to myself, Dr. Greeno, as well as Laura Fangle, who's our RN coordinator for the cancer program. And we basically keep track of everyone who's been requesting for NCDB PUF files. And with that, I'm going to turn it over to Shlomo, who's going to talk to us about some of the projects that we've utilized NCDB for.
Thank you for your presentation. All right, so next up, presenting an application of the National Cancer Database and how it can be used in research is Dr. Shlomo Marmor, who is an assistant professor in the Department of Surgery at the University of Minnesota Medical School. Dr. Marmor has extensive experience working with large, complex healthcare data sets and has collaborated with clinicians as well as senior industry leaders to provide actionable solutions that maximize healthcare efficiency. With that, Dr. Marmor.
Thanks so much for the introduction, and thanks so much for listening to us today. We just started working with the NCDB, as Jane mentioned. It's something that we've been eyeing for quite a while, but given that we most recently became Commission on Cancer members, we're given access to the data. And so I think it's really an exciting opportunity for researchers across the university to tap into a resource that has not been available to us in the past. Oops. Just getting to my slides here. And I just want to go ahead and thank the co-authors that have worked with us on this particular example that I'm going to share with you today. They are particularly in the Division of Surgical Oncology, but also across the medical school. And I wanted to also give just a snapshot or a screenshot of what you get when you get the data. I think sometimes folks are a little bit overwhelmed when they think about the files that they're about to receive. But this gives you an idea that it's pretty straightforward, especially when it comes to NCDB. It's a little bit of the minutia, but it gives you an idea of the files that you will receive here. This is an example of the breast project that I'm about to present. You get these public use files, and you also get the read-in files for either SAS, STATA, or SPSS. You can, as Jane mentioned, have access to the data dictionary so that you can get a sense for the variables that you would want to look at. And you usually have a summary file as well. So the example that I wanted to present is focused on breast cancer, Oncotype DX, and MammaPrint. And it's a risk score that is given to breast cancer patients to assess their risk of recurrence. And we've had several projects that we've started, but this is an example and is an extension of our work in the national trends of the use of genomic-based testing, and that we're getting ready to submit for publication. So genomic-based testing platforms rely on gene expression patterns to assess disease risk and guide treatment decision-making. These tests utilize a piece of tissue to analyze a panel of genes to predict the risk of recurrence. And the variable that is used to quantify the risk score within NCDB is the collaborative stage site-specific factor. And it's available in the standard research data for analysis in rate and frequency and case listing sessions. So for example, SEER does also provide Oncotype DX scores, except it's by a special request only. It's not typically available in the regular data set. So for this example, what we did was, or what we were interested in was looking at invasive lobular carcinoma and the differences between Oncotype DX breast recurrence score and the 70 gene recurrence assay MammaPrint. So the objectives were to compare the testing and results of the two scores amongst patients with ILC and evaluate the 70 gene score as a prognostic factor and predictive tool for the benefit of adjuvant chemotherapy. This was able to build on some of the work that we've previously done looking specifically at invasive lobular carcinoma. So the previous studies have shown that that there is clinical utility to genomic expression assays to provide prognostic information for ER positive, HER2 negative breast cancer. But most previous studies have included both invasive ductal and invasive lobular carcinoma breast cancer. So what we tried to do was basically narrow the two uses of the risk scores between the Oncotype DX and the MammaPrint risk score. And primarily the Oncotype DX is used more broadly than MammaPrint, but MammaPrint is certainly still clinically used and widely available. And so we wanted to test the power of it. And so we determined that genomic risk category for the MammaPrint was significantly associated with survival, making it a reliable prognostic tool for ILC, and that's been shown in the past. In our Cox models of patients with genomic high risk score with MammaPrint, receipt of adjuvant chemotherapy was not associated with survival. And MammaPrint was a powerful prognostic tool, but not predictive of chemotherapy benefit for invasive lobular carcinoma. So to conclude, I just wanted to give a sense or kind of like a guidebook for users as a summary. NCDB data is relatively straightforward data set to use. It's tailored to answer research questions that focus on defined cancer sites, and it offers some more depth than SEER, but also it's limited to overall survival, 5-year overall survival, and commission on cancer patients. You don't get the broad population-based analytic framework that you would get with SEER. And with that, I'll open it up to questions and comments.
Thank you both for your presentations. I think I'll start us off while we wait for questions to come in with just a brief clarification about any costs associated with the proposal. You need to pay to access the data as part of the proposal, or any other costs?
That's a great question. The data is actually free for COC members, and so really all that you need to have is a data analyst who is able to analyze the data. And again, just like with NSQIP, you know, if you have coding capabilities, then it'll cost you nothing. But if you do need a data analyst, then hours will be required for that. But the actual data itself is free.
What should researchers consider in terms of a timeline to approve their study? You said that the portal's open now 24 hours a day. How long does it usually take to get a project approved?
I would say probably the rate limiting step is for our projects is the surgeon are my availability. And then the other rate limiting step to application would be obtaining that letter of support from Dr. Greeno. So basically the earlier you kind of have that sent off and ready to go, I think that's what's going to speed up actually obtaining the data. Once the application is submitted, it's actually quite a quick turnaround. It's been a little while since we've done the online application, but I believe the turnaround was only like maybe a few days, a week at most.
Great, thank you. And then both of you hinted at this, but oftentimes researchers are trying to decide between the SEER cancer registry data and using that. What in your work do you consider when you're trying to evaluate a question to use one versus the other? And this is for both of you.
Go ahead.
Go ahead.
I was just going to mirror the other panelists in that, you know, it has a lot to do with the research question. Certainly if overall survival or even 30, 60, 90-day survival is an outcome of interest, then the NCDB is actually a great way to look at outcomes of cancer patients. But unfortunately, data such as recurrence or subsequent treatment is not collected. And so there are significant limitations in that regard. In addition, follow-up data is not there either. So for some claims data sets, you can look at, for example, frequency of radiologic imaging. You know, how often do we do CT scans on patients after their first course of treatment? That's not something that's possible with NCDB.
And I would just add that that SEER does not offer comorbidity scores, whereas NCDB does. You're also limited in your ability to assess chemotherapy use in SEER, although that's become a little bit more widely available in SEER. NCDB has that more readily available now.
Wonderful. Thank you both for your presentation. This is a great overview of the data source and how to access it.
Thank you for having us.
Thanks.
From here, thank you both. I am going to move on to our last data source of the symposium today, the Population Assessment of Tobacco and Health, the PATH study. We'll kick off this data source overview by a presentation from Dr. Katie Edwards, who is from the Behavioral Health and Health Promotion Research Group at West. Her research focuses on tobacco regulatory science, tobacco control, and nicotine dependence. And she'll be providing an overview of the PATH study today. Dr. Edwards.
Thank you so much. I can't seem to start my video, but I don't think that's important. I just wanted to do a quick overview of the PATH study. And if I can figure out how to advance my slides. Okay, great. So the PATH study is a nationally representative longitudinal study of tobacco use, which is designed to support the Center for Tobacco Products regulatory considerations. In wave one, we recruited approximately 45,000 youth and adult respondents in 2013, 2014, with yearly follow-up waves until wave four, which was in 2016, 2017, and then moved to data collection every 2 years in wave five, 2018, 2019. There was also a special collection of youth data fielded in the interim year. We called that wave 4.5 in 2017 and 2018. So the longitudinal design of the study allows researchers to track tobacco product use and changes over time, including product initiation, cessation, and relapse. Since the interview asks about a large array of different products, researchers can investigate polytobacco use, switching between products, the emergence of nicotine dependence, and other health conditions that may be related to tobacco use. The PATH study also collects biospecimens from respondents, some of which are analyzed for biomarkers of exposure to various toxicants. So these are the wide array of tobacco products that the PATH study asks about. It includes cigarettes, e-cigarettes, or other electronic nicotine delivery devices, pipes, smokeless tobacco, including snus pouches, and cigars, including traditional cigars, cigarillos, and filtered cigars. The health section of the instrument is very detailed. It includes questions about physical, mental, and behavioral health. This section utilizes components of validated scales like the Patient Reported Outcomes Measurement Information System, or PROMIS, to assess physical health, and the Global Appraisal of Individual Needs, or GAIN, short screener to assess symptoms of substance abuse and mental health difficulties. There are questions about the respondents' perception of tobacco use on their own health, and questions about whether their healthcare providers advise them not to use tobacco. Also in the health section, there are questions about tobacco-related health conditions such as heart conditions, lung and respiratory conditions, and cancer. Respondents are asked about from a list of over 30 different types of cancer. And there's also questions about dental conditions, ulcers, GI bleeding, and questions about whether the respondent is currently pregnant or has been pregnant, the outcome of any pregnancy, and their use of tobacco and alcohol during pregnancy. For each condition, there are usually questions about diagnosis, age of diagnosis, and sometimes medication use. For biomarker data, urine and blood specimens were collected from respondents in wave one. A subset of these were selected for analysis for various biomarkers of tobacco exposure and potential harm. For those who were selected at wave one, urine was collected from them again at each subsequent wave, but blood has not been collected since wave one. And then data for each assay panel is in a separate data file. So the biomarker restricted use files are released on a rolling basis, but the urine assays that are available include panels for nicotine and its metabolites, tobacco-specific nitrosamines, polycyclic aromatic hydrocarbons, volatile organic compounds, metals, creatinine, speciated arsenic, and isoprostane. And wave 4 data is still forthcoming for PAHs and VOCs. And then for the blood and serum assays, which we only are available at wave 1, we have serum cotinine and hydroxycotinine, HSCRP, IL-6, SICAM, and fibrinogen. So the PATH study utilizes a 4-stage probability sample designed to draw a nationally representative sample. Therefore, population and replicate weights were created that adjust for the complex study design characteristics, such as stratification and clustering within primary sampling units and oversampling. The weights also adjust for non-response at each wave, and special urine and blood weights were created for the use of biomarker data. When analyzing PATH study data, it is necessary to use the weights to produce results that are nationally representative. If the weights are not used, the results will only represent the sample and not the target population. Special analytic techniques are needed to use the weights, and these are described in detail in the PATH study user guide. There are a lot of resources for those interested in working with the PATH study data. This link here at the top provides information about the study overall, and then provides other resources, including documentation such as user guide, code books, and annotated instruments. If you have any questions about the PATH study data, you can email pathdata user questions@westat.com. All the data are available in restricted use files. This includes the biomarker data, state identifier data, and others. And these files are available earlier, but you must apply for access, and if approved, use them on NADAP's virtual data enclave. Some of the files, including the adult, youth, and parent questionnaires, are made available in public use files, which can be downloaded anytime, anywhere. And then for those interested in more kind of background on the design and content and documentation, we have a Path 101 webinar you could view. And for researchers interested in analyzing biospecimens from the PATH study data, urine or blood, they can apply to the Biospecimen Access Program. And priority is given to research designs that align with PATH study or tobacco regulatory science research priorities, but any resultant laboratory data can be linked to the existing questionnaire or biomarker data. And there's more information at the website listed at the bottom. Thanks.
Thank you, Dr. Edwards, for that presentation. And before we take questions on the PATH study, I'd like to introduce our final speaker of today, Dr. Dana Carroll, who is an assistant professor in the Division of Environmental Health Sciences in the School of Public Health at the University of Minnesota. Dr. Carroll is an epidemiologist, and her work is committed to reducing health disparities, particularly driven by commercial tobacco use. Her research spans a continuum from analyses of large epidemiologic surveys to clinical trials and community-based participatory research. She will be presenting today on an application of
Thanks, Helen, for that introduction. And let me share my screen over there. Okay, so I think everyone can see my screen. It's great to be with you, and especially as in Minnesota, it's starting to get a little dark here already. So thanks for hanging on to this last session. So as Helen mentioned, I'm going to provide an application, a couple examples of how I've used the PATH study. And this is an exciting presentation for me because I've utilized this resource multiple times. So to be able to tell you guys about how I've used that is great. So I just wanted to first mention that I've been able to use, my colleagues and we've been able to use the PATH study in various publications, as you see here. I've also used the PATH study in grant applications and proposals, as well as just trying to develop future avenues. I've used the PATH to explore potential questions of interest. So this is a really helpful resource for me and in my work in commercial. I'm going to present today on two examples of using the PATH that I think give a flavor of the type of research questions that the PATH can be leveraged for. I do want to mention that the examples I'll be discussing are with the adult data. That's because it's my interest is looking largely at adults. But as Katie mentioned, youth data is available. I also am just presenting some cross-sectional data from either the first wave or the fourth wave of PATH, just for brevity of this presentation. But as also mentioned, longitudinal data is available as well. So the first study example I wanted to just mention was one that was recently published in Cancer Epidemiology's Biomarkers and Prevention by my colleagues and I. And this looks at the impact of cigarette filter ventilation, so a characteristic of the cigarette itself and how that may or may not impact smokers' exposure levels as well as their perceptions. And I don't expect you to fully track with me on all the details of why we proposed to pursue this study. But essentially, the tobacco industry added holes into the filters of cigarettes to dilute, to filter the smoke and dilute it with air. And smoking machines showed that reduced exposure. But what we now know is that people don't smoke like machines. They're able to smoke harder on a cigarette or for a longer duration or smoke more cigarettes per day. And that doesn't necessarily lead to lower exposure. And so there have been a lot of research on this topic. There just had yet to be one that was really comprehensive, looking at an array of biomarkers as well as perceptions and how that relates to the filter ventilation of cigarettes. So just some data considerations. As Katie mentioned, there are two ways to access the PATH. There's the public use data set, and then there's also the restricted use data set, which allows you to get access to another level of the data that includes the biomarkers. So that required us to get approval for that. And I can talk more about that process during Q&A if folks have questions. And what I find really unique and novel about the PATH data is the level of detail on cigarette brands that are collected. So most surveys do not have the actual brand and subtype of cigarettes that smokers use, for example, like Marlboro Red 100s or Newport Menthol Kings. So that level of data is available. They also have questions on their perceptions of their usual brand. And then what I think also is a really interesting or novel resource in the PATH is the length of biomarkers that are included. So we looked at urine biomarkers of exposure, which included nicotine metabolites, tobacco-specific nitrosamines, polycyclic aromatic hydrocarbons, and VOX. We also were able to look at biomarkers of potential harm, which again, I think is a really cool component of the PATH study and resource. So we were able to look at some common biomarkers of inflammation and stress. And then what I also think is pretty unique about this example, this research paper that we did, is that then what we did is, so the PATH had all that data, and my colleague, Dr. Irina Stepanov's lab, had data on filter ventilation level of the cigarette brands. And so we were able to merge those data sets together to create a data set that we were able to use to answer our question, whether filter ventilation in the brands did associate with biomarkers and perceptions. And essentially what our findings show, and I'm just showing here the results for total nicotine equivalence, which is commonly coined as the gold standard measure of nicotine dose from the cigarette, which often is then associated with several of the other biomarkers because people smoke for the nicotine, is that we saw that the biomarkers did not differ by filter ventilation. So even though people had higher ventilated cigarettes, their biomarkers were no different than those with lower. And what is unique is that in the same data set, we also show that, however, people perceived their brand as less harmful if they were smoking those higher ventilated cigarettes. So in other words, a misperception exists where folks find their brands with more ventilation less harmful, but yet their biomarkers in the urine and blood don't reflect that. So we recently published that study and contributed to that body of literature. And then briefly, because I think I probably have 1 minute left, is another paper that I just wanted to mention because I think it really looks at cessation, so a different angle using the PATH study. So as many of us know, disparities in smoking and related health outcomes exist across racial ethnic groups. And so my colleague and I were interested in conducting a US representative study looking at racial ethnic differences in quitting and prevalence of factors that can influence smoking cessation, with the goal that findings may help highlight areas that should be targeted in smoking cessation programs that can ultimately help achieve health equity. So again, the PATH had some, in this case, had everything we needed. Participant characteristics, also information on factors that have been shown to relate to smoking cessation, so FDA approved medications, their use of them or not, behavioral counseling, also other tobacco product use in the past. And we also added information on, looked at mental health and sleep health, because that's been shown to impact quitting success. And what we showed was really not a surprise, but and if I can note, one of the interesting, the great things about PATH is the diversity of the participants. So you see white, American Indian, Black, Asian, and Hispanic. And what we were able to show is that quit rates were lower among some of the racial ethnic minority groups. And then later in the paper, we discussed that there are certain factors that can be targeted or improved upon in these groups. And for example, with Native Americans, we saw higher levels of mental health and sleep trouble. And so perhaps smoking cessation programs that also target these would be important for Native Americans. And we did that analysis for the other race groups, but just highlighting that group for brevity for today. And that is all I have. I'm happy to take questions.
Thank you, Dana, for your presentation. That was a great overview. So we do have a number of questions. So let's start off. One of the first questions is for Katie. How can you access the biospecimens, and does it cost anything?
Sure. So we do have a biospecimen access program that researchers can apply to. Essentially, priorities given to folks whose questions align with tobacco regulatory research priorities or PATH study research priorities. But all are welcome to apply for access to the biospecimens. And the nice thing about these specimens is that we already have so much data on them from the PATH study questionnaires. You have, racial ethnic information, you have perceptions, attitudes, beliefs, all that can be linked to your resultant data. So there is no cost for applying. There is a review schedule that's posted on the Biospecimen Access Program website, which was on my last slide. And so folks who are interested can just look at the schedule and submit a concept statement, which we would first review to make sure that we have specimens that meet your needs available, and then if approved, you can submit a full application.
Great, thank you. Related to that question, I had another follow-up. You mentioned in your talk that there are a set of restricted use as well as public use files. Could you just briefly give us an overview of the process for requesting those two different types of files, and if there's any cost associated with one versus the other?
Sure, there's no cost associated with accessing any of the files. The public files can be downloaded directly from NADAP's website. So the PATH study page on NADAP, you can directly download the adult questionnaire, the youth questionnaire, or the parent questionnaire from any wave that's currently posted on the website. The restricted use file application process is a little bit more cumbersome. Dana may be able to speak to it as well, but essentially you need to have a research question and know exactly which files you're interested in, whether it include the biomarker restricted use file, the adult restricted use file, for example, and submit that to NADAP, and then they will review it. And you also have to submit IRB approval, and they're usually fairly quick about that. So I think, approval for the access to the restricted use files is usually within 2 weeks. And then you just have to use the data within their virtual data enclave. And there's also kind of a process that you go through to export your data or to get, data tables out of the enclave as well. So all of that is available on the website.
Yeah, I don't think I have anything to add to that, Katie. Essentially, they have it set up nice that you can peruse all the variables, and you might not need to have to request access to the restricted use data set. But if you do want the biomarkers, that's for sure restricted. And I think if I'm recalling, some of the race ethnic groups are only available due to small sample size and restricted. So those are kind of some examples. And once you do your initial application, you get access to the system and essentially do all your data analyses in that kind of lockdown system. And as Katie mentioned, pretty much you complete like a data request describing what your data for request looks at, how you're using it. And within, I would say about 10 business days or sooner, depending on the load of which reviews they're doing, they'll get it back to you. But that window of review, I have to always then kind of backdate myself with any deadline, if it's a presentation or a conference submission, to just be aware that it's not right away.
Thank you both for that. Well, we have come to the end of our speakers today, and before I turn it back over to Deepa, I'd just like to thank all of you for your time and overview of these resources that you work with day in and day out. So thanks again for sharing your research and your lessons learned. I really appreciate it. All right, and with that, I'm going to turn it back over to Deepa.
Thank you, Ellen. First, I would like to thank all the speakers for such a wonderful presentation. It was a big learning experience for many of us here. We can see all the different data resources put together, and I'm sure this is going to be very informative for many of us here in cancer research. I would also like to thank Helen to serve as a moderator for all these sessions and for the and also to be on the planning committee and, identify the speakers. I also like to thank all the faculty planning committee members, as I mentioned earlier, for bringing such a wonderful topic to table for us to have today's meeting. Before we conclude, I also want to thank a few people here behind the screens who have worked really hard to have this symposium a grand success. First of all, Nicholas Lodge, who is our AV specialist, for running this meeting without any interruption or without any, without any flaws. I also want to thank Max Huber, our marketing manager, for sending the invitation to all the people who we thought might be relevant, who might find this meeting to be relevant. And I want to thank the audience for staying all through amidst a snowy day. And I want to let you know this meeting is recorded. So if you would like to review the slides, let me know. I will be able to share them with you. And also if you have any suggestions for topics towards the next seminar or symposium that could be held by CRTI in the following years, please send it again to me. I'll be happy to review them and plan for the next meeting. Thank you everyone for staying with us all through this 2.5 hours. Have a great evening and have a good night.